This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the Annals of Medicine, published in 2026. It's titled, The Clinical Utility of Intraoperative Blink Reflex Monitoring and its Synergistic Value with Lateral Spreading Response Monitoring in Predicting Postoperative Outcomes in Patients with Hemifacial Spasm following microvascular decompression.
This is a topic near and dear to any functional neurosurgeon's heart. Hemifacial spasm, or HFS, is a chronic neuromuscular disorder that can be quite debilitating for patients. Not life-threatening, but certainly life-altering due to the social discomfort and psychological distress. We see it mostly in middle-aged patients with a clear female predominance. The global prevalence is about 14.5 per 100,000 for women.
Exactly. And as we know, the core mechanism in over 90% of primary HFS cases is vascular compression at the facial nerve root exit zone, usually the pica or ACA. The paper touches on those two major pathophysiological hypotheses, the peripheral hypothesis, which involves demyelination and epifactive transmission between nerve fibers, and the central hypothesis, which posits hyperexcitability of the facial nerve itself.
Right, and microvascular decompression, or MVD, remains the definitive treatment to achieve a radical cure. But the challenge has always been intraoperative confirmation. We use BAEPs for auditory safety and EMG for facial nerve protection. But when it comes to assessing surgical efficacy during the case, we've traditionally relied on the lateral spread response, or LSR.
And that's where this study gets interesting. While the disappearance of LSR is a classic indicator of adequate decompression, the authors point out that discrepancies between LSR findings and clinical outcomes still persist. They wanted to see if adding blink reflex, or BR, monitoring could bridge that gap.
This was a prospective cohort study out of Beijing, correct?
Yes, from the Beijing Neurosurgical Institute and Tantan Hospital. They followed 105 patients with primary HFS undergoing MVD. What makes this study robust is that they didn't just look at one branch of LSR. They monitored both the zygomatic LSR, the zygo-LSR, and the mandibular LSR, the man-LSR, and then integrated the blink reflex.
Let's talk about the feasibility first. One of the common critiques of adding more monitoring is the elicitation rate. If you can't get a baseline signal, the monitoring is useless. What did they find regarding the BR?
The BR actually performed exceptionally well. It had an elicitation rate of 99.0%. That's actually higher than the zygo-LSR at 97.1% and the man-LSR at 91.4%. So from a technical standpoint, it's a very reliable signal to capture under anesthesia.
That is impressive. Now, the core of the paper is how these signals predict the patient's status at the 3-month mark. We all know that HFS often has a delayed cure phenomenon, so immediate postoperative results can be misleading.
Precisely. The researchers used multivariate logistic regression to identify independent predictors for postoperative spasm at 3 months. They found that if the signals persisted after decompression, the odds of the patient still having spasms were significantly higher. Specifically, persistent zygo-LSR had an odds ratio of 28.99, persistent man-LSR had an odds ratio of 12.06, and persistent BR had an odds ratio of 10.38. All of these were statistically significant with p-values less than 0.05.
So if any of those signals stay active after you've placed your Teflon felt, you should be concerned that the decompression might not be sufficient. But the real value add here is the synergy mentioned in the title. They compared 2 predictive models, correct?
They did. Model 1 was based solely on LSR findings, the traditional way. Model 2 combined LSR with the BR findings. They used ROC curves, receiver operating characteristic curves, to quantify accuracy at 4 time points: 1 day, 1 week, 1 month, and 3 months post-op.
And what did the synergy look like in the data?
The performance of both models actually improved over time as the delayed cure settled out. But looking at the 3-month mark, Model 2, the one including the blink reflex, showed a numerically higher area under the curve, or AUC, of 0.955. Compare that to Model 1's AUC of 0.901.
Now, for the residents listening, an AUC of 0.955 is incredibly high for a predictive model. It suggests near excellent accuracy. But was the difference between the 2 models statistically significant?
That's the nuance. When they used the DeLong test to compare the 2 models, the p-value was 0.083, so it didn't quite reach that traditional 0.05 threshold for statistical significance, but the authors argue that it shows a clear trend toward improved accuracy and warrants further evaluation in larger studies.
I think that's a fair assessment. If I'm in the OR and my LSR has disappeared but the blink reflex is still abnormal, I might spend a few more minutes looking for a secondary offending vessel. It speaks to that central hypothesis we mentioned earlier. If the facial nucleus is hyperexcitable, the BR might reflect that state more accurately than the LSR alone.
Exactly. The paper suggests that intraoperative BR monitoring is a feasible and potentially useful adjunct. It gives us a more comprehensive view of the facial nerve's functional state.
It's also worth noting that they focused on primary HFS. This is a very specific population. We have to be careful about extrapolating this to secondary HFS caused by tumors or other lesions.
Agreed. And the study emphasizes that the fundamental therapeutic principle is the alleviation of vascular compression. INOM tools like BR and LSR are there to assess that efficacy in real time.
This definitely gives us more data to support multimodal monitoring. Instead of just asking, is the LSR gone, we should be asking, what is the status of the entire reflex arc?
It's moving us toward a more refined version of efficacy monitoring. Instead of a binary yes-no from the LSR, we're getting a more nuanced predictive picture.
Well, this has been a great dive into a very practical paper. For our listeners in the OR, consider talking to your neurophysiologists about incorporating blink reflex monitoring into your next MVD.
It's all about improving those long-term outcomes for our patients.
That's all for today's episode of the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. See you next time.